Good evening, everyone. Thank you for making some time to hear my presentation on the Oncotype DX colon cancer assay, optimizing stage 2 and stage 3 colon cancer management. I'd like to actually give you some new considerations for this assay, which of course has been available since 2010. But in the last couple of years, we've gained some new insights from the IDEA trial analyses in stage 3 and also in stage 2 colon cancer. And I think that the field has become more interesting recently because of new opportunities in assessing risk in the disease. So what I will do is go through a little bit of historical context. I'll review briefly again the 4 validation studies for the Oncotype colon assay. And then we'll talk a little bit about some future directions and projects that we're working on to give you some insight into what improvements you may expect in the coming months to years. I'll start off by sharing, I think, this study that is familiar to all of us, the Mosaic trial. And I think of all studies that have been done in early stage prostate cancer, colon cancer, probably the Mosaic trial has been the most impactful in giving us a great understanding of how to treat patients with adjuvant therapies. And yet I think what we can really focus on are the actual risk levels that we see for stage 2 and stage 3 colon cancer patients. Of course, in Mosaic, we know that in stage 2, there was really not a clear demonstration of clear benefit from the adding of oxaliplatin to 5-FU chemotherapy. But in some sub-analyses that were unplanned, there was a very small incremental benefit in high-risk stage 2 patients, and hence that has been, I think, with us ever since that time, that some patients have received even the maximal chemotherapies for those high-risk stage 2 patients. But let's take a look at the box down at the lower right, where we can see the actual risk levels. With 5-FU chemotherapy, an 80% probability of survival at 5 years, and with oxaliplatin, really a very small increase of maybe 3.8% for stage 2. And for stage 3, the absolute benefit goes up by 7.5% with oxaliplatin, where patients have clearly worse risk, but it's clear that not everybody has a recurrence. And I think the message I'd like to leave with you is that in stage 3 colon cancer, it's still unclear exactly does everybody need chemotherapy? I think the guidelines say yes, but it's very clear that still half of the patients do not recur, and they probably were cured by surgery alone. So we still have to think about the spectrum of treatments that are available to such patients. If we look at the NCCN guidelines for colon cancer, we see that for patients who have T3 and N0 disease, patients can still receive either no therapy, observation, or capecitabine or 5-FU monotherapy. Even patients who have higher risk T3 N0 disease, we also see NCCN recommends the possibility of receiving oxaliplatin through FOLFOX or CAPOX. And certainly T4 N0 disease, the same. FOLFOX or CAPOX are options, but still observation is still yet another consideration. So really, we have not advanced the field so much in the last decade or so. This pretty much remains the same set of recommendations that we had in 2010 when the Oncotype first came out. The other observation is in stage 3 colon cancer. We now split those into low risk and high risk stage 3 by the T and N stage. For patients who are largely T3 N1, low risk stage 3, the IDEA meta-analyses have shown us that 3 months of CAPOX may be the preferred therapy for such patients, but we still have NCCN recommending as options 6 months of FOLFOX or CAPOX. And for the higher risk stage 3, T4 and or any N2, we see that patients should get more aggressively treated. But again, the guidelines suggest that 3 months of CAPOX is still an option. And again, more evidence from the NCCN guidelines where they have carefully looked at various elements of efficacy, safety, quality of evidence for the different drug recommendations. I think in general, when you look at stage 2 up at the top table and stage 3 at the bottom table, what we really have are more options today. Because of the IDEA study, not only do we have the type of regimen to use if we want to use chemotherapy, but also the duration of the oxaliplatin should we decide to give that. And if anything, that there are more options today than there were before. And so this really introduces more decision or thinking about what exactly is the proper treatment. And all of this hinges on accurate risk assessment. So that's really what it comes down to. And same thing with ASCO, very similar types of guidelines, again, pointing out that for stage 3, higher risk patients, 6 months of oxaliplatin-based therapy, although admitting that the strength of recommendation is only moderate and the evidence quality is intermediate. Same thing with the lower risk stage 3, 3 or 6 months, again, intermediate quality and moderate strength of recommendation. And so the conclusion really is that there should be a shared decision making. ASCO says we must consider everything about the patient's tumor characteristics, the resection, the number of lymph nodes examined, comorbidities, functional status, performance status, and other sort of judgments and values, preferences, age, life expectancy. All of these things should be considered. And at the end of the day, it all rests on what is an accurate assessment of this patient's risk of recurrence. This is really what then it becomes important. And as we look at the IDEA study breakdown of, this is from the landmark New England Journal article from Axel Grothe, we see that stage 3 patients, whether they are low risk or high risk, they actually have, it's not as terrible of an outcome as we once saw maybe 15 to 20 years ago. What we see is that the increment of adding 3 extra months of oxaliplatin doesn't get you so much really. Even in the high risk, the amount of benefit extra is really only a couple of %. And so I think this is worth keeping in mind. As well, it's worth keeping in mind that there are many, many patients who do not recur at all. Of course, these are patients who all got some kind of chemotherapy, but I think the big question is, how much would have been the risk if you had just surgery alone? How much would be the risk if you had 5FU added to that surgery as monotherapy? And how much would you have when you add the oxaliplatin at 3 months and at 6 months? So we will get to that as we get through our data. The other piece of data I'd like to share with you is this analysis in the United States, where this was a review of the National Cancer Database US data registry, looking at stage 2 and stage 3 colon cancer and how it's managed in the US. On the left, you see that it's about a 50-50 split between stage 3 and stage 2. And stage 2, you can see that the data review was able to identify those at high risk stage 2, defined by T4 stage, high grade, positive margins, or lymph nodes assessed less than 12. And what this does is it splits the stage 2 population roughly in half. But half of patients being high risk in stage 2 is probably too much, because I think we all agree that stage 2 largely is a good outcome with surgery alone. And it's only the minority of patients that probably need some kind of chemotherapy. And yet, I think if we use the parameters that are recommended by the NCCN guidelines and all other guidelines, the clinical pathologic features probably err on the side of over-identifying high risk. And I think if you think about these criteria today, of course, T4 stage is important high risk. That's only a small minority of patients in stage 2. Lymph nodes assessed less than 12 should not exist so much today as it once did in the past, because it's a quality metric for many hospitals to get at least 12 lymph nodes surgically removed and assessed by the pathologist. Positive margins also shouldn't happen so much. I think the main factor that really contributes to this high proportion of high-risk patients is the high grade. So how good is high grade? And I'll get into that. But when we look at stage 2 patients in the middle graph, we can see that there's a wide variety. This is a hospital, 1,383 hospitals were looked at to see what proportion of patients actually get chemotherapy in stage 2? It's as low as below 10% to as high as maybe 40 or almost 50%. And so the average is probably a little around 15%. So that's what we see today in practice. But in stage 3, I'm surprised to see that not everybody gets chemotherapy. But I think that that's telling you that the physicians are using their judgments to decide who should get chemotherapy and who should not get chemotherapy. The average mean is only 65% getting adjuvant chemotherapy. So the other 1/3 of the patients aren't getting chemotherapy, which is a little bit surprising, but I think a good observation given the fact that not everybody recurs with stage 3 disease after surgery. So let's revisit tumor grade, because this is a very important driver of the ultimate decision if you don't order a multi-gene assay. And the history behind grade and colon cancer really comes from the literature over the last several decades, going back to the 1970s and 80s. But a lot of these cohorts are lumped together in all 4 stages of colon cancer, and probably driven by stage 4 colon cancer patients. It's really the minority that had stage 2. And so a lot of the thinking behind high grade being a high risk factor comes from these very old studies. If we look more recently at stage 2 colon cancer studies, these are several studies that actually identified their stage 2 patients. And you can see that largely the grade did not seem to perform in the way that you expect as a high-risk feature. In fact, the hazard ratios are generally less than 1, suggesting that high grade in stage 2 seem to directionally correlate with better outcomes than patients with low grade. And that may be because of really inconsistent, non-standardized ways of defining grade. Some regard the mucinous histology as included as high grade, and these patients often are the MMR deficient types of patients who have a very good outcome. So this really is quite confounded in stage 2. And if we look more closely at the PETAC3 trial, which was a trial of irinotecan in stage 2 and stage 3 patients, let's take a look at the factors that came out most significant in all patients on the left. You can see that end stage, whether it's N1 versus N0 or N2 versus N1, were of course highly significant and important determinants of risk, as was the MSI status down at the bottom. Grade, on the other hand, was really not a strong performer. In all patients, it was marginally significant statistically with a hazard ratio of 1.43. But in stage 2, notice that the hazard ratio flips in the other direction to 0.93 and is not significant. And stage 3 alone, it's again loses its statistical significance. If we look only at MSI stable patients, right, you take out the MSI high patients, and now we see that grade has lost its significance altogether. So again, the same magnitude of the hazard ratio is seen driven by the stage 3 patients, but now in stage 2, the hazard ratio is now above 1, but not significant. And I think what this means is that grade, we need to rethink the importance of tumor grade in driving the decision for treatment, because it is really a weak prognostic factor, if any at all. And maybe it's more relevant in stage 3 than in stage 2. So we really are dealing with perhaps different disease types when we talk about these different stages of patients. Another analysis that was done by the NSABP in their CO1, CO2, and CO4 and 6 studies, as well as with the Cleveland Clinic, you can see that grade, the hazard ratio goes in opposite directions. For stage 2, where it's actually showing high grade equates with a better prognosis, in stage 3, where high grade equates with a worse prognosis. And so this again speaks to this heterogeneity of tumor grade, and then hence, how reliable it is. So let's take a look at the validation evidence for Oncotype in colon cancer now in stage 2 and stage 3. In summary, I'll tell you that this is the most well-validated multi-gene assay in early stage colon cancer. It has been so since the year 2010 when this assay first became available. There are now 4 validation studies that are high quality studies with very defined risks of assessments that you can get from the recurrence score that helps with the decision in stage 2 and stage 3 colon cancer. Yes, there are other prognostic factors that have been available and some have come and gone, but even today, as we have new ways of assessing risk, this data is still unparalleled. We don't have anybody who has produced a multi-gene assay that has been so well studied as the Oncotype DX. So when we think about this development work and then the validation studies, these 4 validation studies really has paralleled the progress we have made in stage 2 and stage 3 colon cancer management. Yes, we started with Quasar, and that remains the study on the report. But this Quasar study is now pretty old. You can see it was 1994 to 2003. And as each subsequent validation study was produced, it used patients that were more and more modern and closer to recent times. The last one being the Sunrise study, which I'll share more detail with you later. But I think it's important to know that there has been this progression of different studies in stage 2 and stage 3 in time, meaning that the patient populations may have actually been getting a little bit better and better in risk characteristics because of better lymph node assessment and other improvements that have been made in surgical management. The colon cancer assay has 7 recurrence score test genes representing 3 separate groups. And the cell cycle genes are proliferation genes correlating with worse prognosis. But importantly, I think the stromal genes are worth mention because these, when highly expressed, represent the host's immune response. So we know that there are other tests available that measure strictly immune response of the host, but the Oncotype DX actually bakes that into the assay. So in other words, if you're, we agree that immune response is very, very important, and the higher the immune response of the host, the more likely that the patient is able to have a better outcome and a lower risk cancer. And so this is actually baked into the recurrence score, but as important, of course, are the proliferation genes and then the GAD45B gene by itself. So I think all along we've actually represented the biology of the tumor very accurately. And in the first validation study of Quasar, you can see that in this pre-specified multivariate analysis in stage 2 disease, we can see that the recurrence score per 25 units was associated with a hazard ratio of 1.61 and a highly statistically significant outcome when controlling for all these other factors: MMR, T-stage, grade, number of nodes examined, and lymphovascular invasion. The 3 most important variables turned out to be MMR, T-stage, and the recurrence score, and that has what has appeared on our report. But I think it's also worthy of mention that the number of lymph nodes examined in this study was important to recognize that 62% of the patients had insufficient lymph nodes examined, and it was an important risk factor because roughly 50% elevation of risk if the patients had less than 12 nodes examined. So more on this later, because we are contemplating about how to actually provide you with more accurate information coming from the recurrence score if we can also control for the number of lymph nodes examined. Hopefully today, most patients are getting at least 12 nodes examined, and their risks should be lower than what you might see based on these older studies. Here's the graph that actually produced from Quasar is given to patients. The middle curve is the most relevant one in the T3 MMR proficient category, where we see that this is 75% of the patients roughly. And generally speaking, we point to the recurrence score of 41 as a cut point for separating the high-risk patients from everybody else, the lower risk patients. And you can see that about 25% of the patients in Quasar had higher risk recurrence scores, and these patients have a much higher risk of well over 20% as opposed to the patients down at the lower risk range. Again, I would suggest that these risks that we see today on the curve of quasar is probably higher than what you really expect in reality, because again, 62% of the patients had insufficient lymph nodes examined in this study. The original paper for the quasar validation study introduced the concept that one could apply a relative benefit from 5-FU monotherapy. The blue curve is surgery alone, and the yellow curve, the effect of benefit from 5-FU chemotherapy. And you can see that in general, when the recurrence score is lower, we see a smaller marginal benefit from chemotherapy from 5-FU, but in the higher recurrence scores, obviously this widens to a larger absolute benefit. And so this remains the premise of how we recommend approaching the patient, giving the patient a quantitative estimate. What is this patient's risk of recurrence to begin with? Is it overall good or bad? And then how much more am I going to benefit this patient by giving him this chemotherapy? In the second study, the CALGB 9581, we actually took stage 2 colon cancer patients that were generally lower risk than in quasar. You can see that the 5-year risks were only 14.6% compared to 21.7% in quasar overall. And that's because the cohort had fewer T4 stage patients and more MMR deficient patients, and perhaps more patients that were older, fewer lymph nodes, fewer patients had less than 12 lymph nodes examined, although still 47% is quite a high number. And overall, I think what we came away with is that this is a generally lower risk population, but when you apply the same pre-specified multivariate analysis with the same variables we saw earlier, we have a very consistent outcome for the recurrence score. In this study, it was the only factor that came out statistically significant. All of these other features did not perform as important risk factors in a multivariate analysis. And I think this speaks to the strength of the recurrence score as an important measurement if you really want to characterize the risk accurately. And the third study was now a study that went into stage 3 colon cancer as well as stage 2. And this NSABP C07 study looked at 5-FU plus or minus oxaliplatin therapy. And what we saw once again is that the nodal status is important, the stage of the disease, as well as the treatment effect was observed to have some contribution of the risk. But the recurrence score, once again, factoring in these other features, for every 25 units reflected almost a doubling of the risk. And so this, again, is speaking to the fact that not only in stage 2, but also in stage 3, the recurrence score is an important measurement to have if you want to give an accurate assessment of the patient's risk of recurrence. In this study, we actually enabled physicians to visualize what the effect of adding oxaliplatin would be to a stage 3 patient with stage 3A and B disease, meaning that the patients only have 1 to 3 positive lymph nodes and T3 tumors. These patients actually have very small incremental benefit from adding oxaliplatin with, of course, quite a bit of toxicity, but at the low score range. But if the scores are higher, then obviously the patients have larger and larger absolute benefit from oxaliplatin. The same thing with the stage 2. You know, many guidelines still recommend using oxaliplatin, or physicians believe that it's warranted to give FOLFOX if you're going to give any chemotherapy at all. Well, we would argue that, frankly, if you look at the low-risk stage 3 patients and the high-risk stage 2 patients by recurrence score, they really do have comparable risks and comparable benefits from adding oxaliplatin. So if you would not actually use oxaliplatin in some patients in stage 2, why would you want to do that in the low recurrence score stage 3? So this really, I think, gives you a nice visual comparison of how one might want to reasonably approach patients' treatments. In this study, there were also still plenty of patients that had insufficient lymph nodes examined. You can see that 64% had more than 12 nodes, so therefore 36% still had less than 12 nodes examined in stage 2. And in this report that you now see today, as you order the test, one graph is showing you the stage 2 quasar results that gives you a numerical answer of what is that patient's risk of recurrence. And here you see it's 13% in the T3 MMR proficient patient at 3 years. Over on the right, you can see for that same recurrence score of 20, of course, on the left, this is with surgery alone from quasar, but on the right, we can see what are the risks if you use 5-FU and if you use oxaliplatin with 5-FU. And again, this would be 9% and 7%. So again, these are coming from different studies, but I think, and you have to caveat this with the fact that quasar is much older than CO7 and had a different number of lymph nodes assessed. So that might affect this, inflate this 13% a little bit. But on the right, I think you can see that the amount of benefit from adding the oxaliplatin is pretty small for this kind of a patient, only 2%. So now the last study out of Japan is called Sunrise, looking at stage 2 and 3 colon cancer patients treated with surgery alone. And once again, we see a near doubling of the risk for every 25 units of the recurrence score. And controlling for stage, this was highly statistically significant. So this was something that was done in a population of patients in Japan where back in 2005, when this study completed its accrual, we see that patients were largely not managed with chemotherapy in Japan in those years. Therefore, this reflects actually the larger population of patients with stage 2 and 3 colon cancer in Japan in this time across 12 hospitals. And we collected the tissues to examine stage 2 and stage 3 colon cancer with recurrence score. And what we produced then is this validation study, where we can see a very similar set of curves to the CO7. But the big difference now, notice how low the stage 2 recurrence score gets. In the low recurrence score range below 30, you can see that the risks start at almost 5% and go up to no more than about 10%. This is much lower than what we see with quasar because the patients are more modern and there are much better lymph node assessments. And even in stage 3A and 3B, you can see that the risks go almost down to 10% and go up to about 23%. So on average, we can see that for stage 2, the low recurrence score group actually represented 60% of patients with only a 9% average risk for the whole group. And for the high recurrence scores, now it's only about 14% of the patients and 19% risk at 5 years of recurrence. That 19% is very comparable to the stage 3 low recurrence score group, which has only a 20% risk of recurrence with surgery alone, no chemo. And so again, we would argue that the low risk stage 3 by recurrence score has comparable risk to the high risk stage 2 by recurrence score. And therefore, why would we not want to treat them similarly with the same chemo regimen? So now this gives us the opportunity to appreciate all 4 studies together as we look at the population of patients studied. And importantly, if the number of lymph nodes examined across these studies was the worst in quasar at 63%, better in CALGB, but still not so good, CO7 was even better, and Sunrise down now to 20%. And again, this was as of 2005. I would hope that in the year 2020, this number of lymph nodes examined less than 12 is exceedingly a small number. I think it is. The recurrence rate, as you can see at 5 years, parallel this kind of trend, where it was the highest in quasar, lower in CLGB, lower in CO7, and lowest in Sunrise also, but I think particularly low in the stage 3 patients, where you can see that the stage 3 patients at 5 years have only a 27% overall risk with surgery alone. So that means 73% of patients are not recurring and were cured by surgery alone in this study. So I think that that's really quite an impressive outcome for today. So then that leads us to the Sunrise Decision Impact Study, which was just completed last year and presented at the ESMO World GI Congress. This is something that impressed a lot of the attendees in the plenary session of that meeting. You can see that the recurrence score was produced on graphs like this and given to the Japanese investigators to see what would be their decision for before and after the recurrence score was available. So this is an example of that same recurrence score of 20. Now notice that with surgery alone in stage 2, the risk is only 9% with no chemo. And in stage 3A and 3B, here's a recurrence score of 12. We can see that this is a low risk with only a 16% risk of recurrence in stage 3 with surgery alone, no chemo. And so then the question becomes, how much more am I going to lower this patient's risk with chemo? Certainly I can give 5-FU alone, but why would you give oxaliplatin? And so this is something that really we have to start asking the question, how much more is this patient going to benefit? And so you can just compare Quasar versus Sunrise, these two different stages of disease for the low recurrence scores, and you can see how useful these numbers can be in thinking about the chemotherapy you want to give and how much more you will benefit the patient. That's exactly what happened with the Japanese investigators, because you can see that pre-assay, the decision was to actually in stage 2, give chemotherapy to about 37% of the patients, but that chemotherapy was split between 5-FU alone and oxaliplatin for 3 or 6 months. After the assay, the 6-month oxaliplatin shrunk to only 6%, and 71% was the no chemo decision. So the patients de-escalated largely their chemotherapy after the assay. And in stage 3A and 3B, you can see that the pre-assay, oxaliplatin represented a good 65% of all the patients, and another 30% was 5-FU alone. But post-assay, impressively, 20% of the patients got no chemo in stage 3 disease, and this surprised me quite a bit. And then you can see the 6-month oxaliplatin was shrunk down to 19%. Generally speaking, the Oncotype DX resulted in de-escalating chemotherapy in stage 3 disease. I realize that today the guidelines do not support this kind of no chemo option, but I think the point is that de-escalation is still possible, even if it means just giving 5-FU monotherapy, or even confidently reducing down to 3 months of oxaliplatin instead of 6. Now, these are all patients that was in the post-IDEA era. So we can see that if we analyze patients that were low-risk IDEA T1 to 3 N1 and high-risk IDEA T2 or N4, you can see in the red boxes that the first 3 columns are representative of the de-escalations of chemotherapy, either shifting from oxaliplatin to no oxaliplatin, a lot of patients there, 14, 6 down to 3 months, 10 patients, and from any chemotherapy to no chemo at all, 22 patients. And these were all low recurrence score patients, even though they all had low risk IDEA where the study itself might suggest you need to give 3 months of oxaliplatin. But these investigators decided that no, we can even go further than that. And even in the high risk IDEA, there was some patients that de-escalated further because of the low recurrence score and the risk estimates that they got, calculating that the absolute benefit wasn't worth the extra toxicity. There were fewer patients that actually escalated their therapies, and I think that the numbers are relatively small for any conclusions there. In summary, in the absence of any predictive factors to date, right, colon cancer is still a disease where it's not like breast cancer where we have something that predicts chemo benefit. So in the absence of any prediction, the premise of adjuvant therapy decisions in stage 2 and stage 3 colon cancer relies completely on accurate risk assessments. How can we make sure that the risk assessment is accurate? Is it enough just to say you have T3N1 in stage 3 and therefore you have an accurate risk? I would suggest that there's a heterogeneity of patients there that can still be clarified with a recurrence score. The IDEA meta-analysis in stage 2 and stage 3 disease has introduced new options, more considerations for not just the chemotherapy regimen, but also the duration of the oxaliplatin we need to give. And so the recurrence score provides quantitative estimates of the 5-year risk of recurrence in both stage 2 and stage 3 disease. And this provides further prognostic value beyond the standard clinical pathologic features. And we know that, again, high risk stage 2 by recurrence score have similar risks to low risk stage 3 disease by recurrence score. And therefore, this has implications for how should we treat these patients comparably. And then finally, by enabling these point estimates for any given patient, you have a recurrence score and a graph, and it says, okay, this is your 5-year risk of recurrence. What then could I infer about the benefits from 5-FU monotherapy versus surgery alone, or adding oxaliplatin to 5-FU monotherapy? And this is something that we would really suggest is it needs to be a more quantitative decision today than a gestalt decision that we have just because of the T stage and N stage. And with that, let me get into now this concept that we're working on, which is to integrate the recurrence score with clinical pathologic risk features through a meta-analysis of the 4 validation studies we just reviewed. I'll start off by pointing out that at ASCO just 2 weeks ago, Alberto Sobrero presented this very interesting analysis of this is the IDEA cohort of patients where he would suggest now, based simply on the accurate T stage and N stage, you can actually determine what is the level of risk for patients. And what they did was some modeling. So remember, IDEA was a study of oxaliplatin 3 months versus oxaliplatin 6 months. It was not a study of surgery alone or 5-FU alone. But what they did was they actually took some hazard ratios that said, okay, we know that 5-FU benefits over surgery alone with a hazard ratio of 0.74. We know that based on literature. We also know that oxaliplatin adds some 16% improvement in risk with a hazard ratio of 0.84 when given for 3 months. And then from 6 months over 3 months, it's a small difference of about 6%. And so what he did was calculate for every one of these T and N stages what the patient's risk would be for surgery alone. And notice that for the most common T3N1A and T3N1B patients, that a good 60-some% of patients would have been cured by surgery alone. So who are those patients, right? Do we want to subject everybody to the toxicity of chemo? And furthermore, we can see that how much improvement, in this case, 9% or 10% would benefit from 5-FU monotherapy. And it's only a small percentage that would benefit from more oxaliplatin. Perhaps if they're young, they would opt for that. But this is something that could be done. I would still suggest, though, that in this T3N1A and T3N1B groups, this is the largest group of patients with stage 3. And we need to get refined even further because there's a heterogeneity of risks. So we would actually suggest that by adding the recurrence score to this, we can see that if your recurrence score is low with a T3N1 disease, we actually can model, and again, this is based on our hypothetical modeling. So this is something we're still working on, but we are estimating that 84% of the patients would be cured by surgery alone. And you would get just a little bit more from 5-FU monotherapy, maybe 3.2%, and just a little bit more from adding the 3 months of oxaliplatin, and really not much more at all with the 6 months of oxaliplatin. Same thing with a high recurrence score. Notice that surgery alone drops down from 84% down to 65% just by changing the recurrence score from low to high in a T3N1 patient. Now the picture looks very different because we should try to be as aggressive as we can to try to get that overall risk of recurrence as low as possible so that we can get close to 80% if we give them maximum chemotherapy. So this again is using these same hazard ratios and modeling, we could produce an RSPC-like tool that could be useful, that could factor in things like tumor grade and number of lymph nodes examined and T stage, N stage, as well as the recurrence score. So this is something that is still work in progress, but we are very, very interested in delivering a tool like that. So this new colon RSPC model may integrate the recurrence score with conventional factors like these different variables, especially the number of lymph nodes examined, because today we're not going to see too many patients with less than 12 nodes. So that means it's going to correct all of our reports to And this meta-analysis using the 4 studies could then generate very accurate 5-year recurrence risk estimates, because there will be very tight confidence intervals, could be a lot more patients, and we can really, I think, give patients a much more accurate picture of what they should expect with their disease. And I think then you can infer what those absolute benefits would be based on this modeling, and decide what kind of treatment they need. And as well, this should impact the clinical utility of the test. So again, this is the largest group of patients in stage 3, have T3N1, and there's a lot of heterogeneity still there, and we need further information to help us decide what is that patient's absolute risk and benefits from the different therapies.
Thank you, Kelvin. If we don't have any more questions, so we'll close for tonight. Thank you so much.
All right. You're very welcome. Thank you all. Thank you very much, and good evening to all of you.